Thank you for the kind introduction, and it's very nice to be here in the cricket ground. As the daughter of a man from India who came to the UK in his 20s but never lost his love of Indian cricket, he'd be very proud to know that I was speaking in here today. So our theme today is on keeping well with CLL, and many people will remain untreated on active monitoring for a very long time, and with that brings a whole load of contentions and issues for people. So I thought what would be helpful as a general introduction and overview of the day is just to talk about how we diagnose CLL, who gets CLL, why we watch and wait, and if and when people need treatment, what are our reasons for doing that. Is it just the down arrow? Yeah. So as doctors, we use an awful lot of terrible acronyms. And I'm sure many of you, when you were first diagnosed, had no idea what CLL stood for. And, and I think as a profession, we're very guilty of not explaining that well enough to people. Moreover, having a condition that has leukemia in the title is very frightening for people. So I often start when I see a new patient just by explaining what the words mean. They've often Googled CLL and come with fears of what they might be told. So CLL stands for chronic lymphocytic leukemia, chronic meaning slow growing, lymphocytic meaning coming from a type of white cell called a lymphocyte, and leukemia is just a Greek word that means too many white cells in the blood. So quite different from the sort of Sunday Times idea of what leukemia is. It's an indolent disease, although incurable. And the other helpful analogy I find for people is to say that in due course you'll come to think of it like having asthma or diabetes or a lot of other chronic problems that people live with and adapt to and are able to get on with their lives. So why people get CLL isn't very well understood. It's not inherited, but there is a familial tendency in first-degree relatives. And there's a group at the ICR where I did some research in the past who are interested in familial CLL. And occasionally we have patients who have a sibling also with CLL, and that group are very interested in exploring more in those families. But there isn't a CLL gene. CLL is more common in older people, in white people, in men more than women, not very well understood why. And lots of people nowadays get diagnosed in very early stage disease because you can't really go anywhere without having a blood test at least once a year. So I've got a number of people in my clinic who hadn't seen a doctor for 20 years, went for a blood pressure check, bang, and they end up on this sort of roller coaster, to use John's expression. So in Wales, based on our population of 3 million and the age-adjusted UK incidence, we'd expect to see about 130, 140 new cases a year, of whom about 1 in 10 are under 55 at diagnosis. And I think our younger patients often feel different from the older cohort, and perhaps with maybe some different needs. So in order to diagnose CLL, you need to demonstrate an abnormal population of B lymphocytes in the blood. So we all produce B lymphocytes that make antibodies and T lymphocytes that have a sort of different role in immunity, but they work together as part of our immune system. So when somebody's first found to have the lymphocytosis in the blood and CLL is suspected, this is a picture of a CLL blood film. So as one of the things actually I love about haematology is the interface between the laboratory and the clinical, and you diagnose the patient based on what you can do in the lab, and then you see them and you can treat them. So that, for me, is very, I like the sort of holistic nature of that. So this is what your blood film might look like if you had CLL. But CLL can look like some of its cousins and relations, other types of indolent lymphoma. So we do a test on the blood called immunophenotyping, and CLL cells have a very characteristic pattern of immunophenotyping. Some people with CLL have enlarged glands or an enlarged spleen at diagnosis, but they're not needed for diagnosis, and many people don't. They just have a lymphocyte count in the blood. So all the patient information that's produced will explain about CLL staging. So the two staging systems, we tend to use the Binet in the UK. Binet was a Frenchman. And Kanti Rai, who's still alive, working in semi-retired in New York. He must be in his late 80s, I would think. And there's both are acceptable and used systems. So stage A, which most people will be at diagnosis, have bone marrow function intact, is the phrase that I quite like. So the bone marrow's working, they're not anemic, their platelet count's normal, and they might have some lymph glands. Stage B has more in the way of enlarged lymph glands, and when you have Binet stage C CLL, then you're starting to have anemia or other issues. So I think so important at that very first visit is the provision of information and understanding. So at the first visit to the clinic, I'll see the patient usually together with Tracy and Sian, who are in the audience, who are going to speak later, because I think people often feel totally overwhelmed at that first visit. I'm amazed, sometimes people come to us and they don't actually know why they've been referred or why they're there, but all they've done is see that they've got an appointment for a haematology clinic, therefore this, in most people's minds, this must be something really, really terrible. And on the back of that, this concept of watch and wait or active monitoring, I think it's really difficult for people because, not only has she told me I've got leukemia, she's told me that I don't actually need treatment. And understandably, that takes quite, faith in the team and knowledge and understanding of what the future might hold. So people come, we introduce CLL, we talk about the concept of watch and wait, we give people written information at that first visit. We then, usually people will be offered a phone consultation a week or two later with Tracy or Sian, because once you've gone away and read the information, then that's when all the questions come. The two other things I just want to mention about management so that I don't forget about these later is we've talked a lot about watch and wait and how the period of time before people need treatment is so variable, ranging from almost immediate to decades or more. So how do you know if you're going to be somebody that will go a long time without needing treatment? The answer is we don't have any perfect tools for that, but there are two prognostic markers that are now widely used in clinical practice and as standard of care, and that's a mutation of a gene called TP53 and something called IGHV or IGVH. So without being too detailed about it, it's to do with the maturation of those CLL lymphocytes and how they develop. So if people have intact P53 that's not mutated or deleted, and if their VH genes are mutated, so there's another confusing bit of terminology, those are the people who, those tests predict a longer time to needing treatment. And I'm just also going to mention vaccinations and the vaccine passport. So if you'd asked me before the SARS-CoV-2 pandemic, what did I think was the value of early diagnosis of CLL, I might have been a little bit sceptical and might have said to you, well, it produces a lot of worry for people who don't need treatment, often elderly people. And I was somewhat sceptical, but we saw very much in the first wave of the pandemic excess COVID-related deaths in our CLL community, even people with early stage disease. And it's really brought home, I think, to the CLL doctor and patient and scientific community how important that is. And on the back of that, really, a very nice joint piece of work between CLL SA and the CLL Forum was the production of this vaccine passport. So we took the Joint Committee for Vaccination guidelines and our own experts within the forum to produce this. So hopefully all people with CLL in this room have got one of these and has seen one of these. You can download it from the CLL SA website. And when I see a new patient, I always give them a hard copy, and I always put a hyperlink to the passport in the bottom of the GP letter. So one of the really key early things, I think, at the start of the CLL roller coaster is to make sure that you're fully vaccinated in accordance with the Department of Health recommendations. So that includes annual flu vaccination. It includes pneumococcal pneumonia vaccination on a different schedule from the standard for people who are not immune compromised. And I think that's not very well understood in the not surprisingly among the primary care teams, because unless they've got a particular interest, why would they know? All COVID boosters that are offered, we say to people, please say yes to it, even if it makes you feel rubbish for a few days after the booster. A few people have said to me recently, I'm not sure I want an autumn booster because I had spent 3 days in bed after my spring booster. But my advice would be still have it. The 3 days in bed is, worth tolerating, I think, if it might give you more protection. And another fairly recent addition to the vaccine schedule is the recombinant shingles vaccine, Shingrix. So until about this time last year, the only widely available shingles vaccine was Zostavax, which is a live vaccine and to be avoided if you have CLL. But Shingrix became available 12 months ago and was initially funded for people of 70 to 79, which is just to fit in with what the Department of Health offer for standard shingles vaccine. And in the last few weeks, it's been announced that the age limit's dropping to 50. So you should all be, if you're over 50, be eligible for that. So this is the one side of the vaccine passport. And the other side has some general information and some links to useful resources. So just coming on to when do we treat, I thought this was worth covering. So these criteria lifted from the International Working Group on CLL, or IWCLL. So in the UK, we adopt that in the UK CLL Forum, and across the world, I think that's pretty standard. So we treat if people are starting to struggle with bone marrow function. So a rule of thumb is hemoglobin of less than 100 and or platelets of less than 100. They'll usually be some warning that that's happening, and many of our patients plot their blood count results, and I love to see people come with their nice graph of their blood results. So we know it's coming before we reach that point, and I think that's important to start having those conversations before we're at that point. Large volume spleen or large volume lymph nodes. Again, it's something that I think when you're new at the beginning of your CLL journey, you know, how big is a big lymph node? I think people often worry about that. So one of the things I quite like is a sort of fruit and veg analogies, which it's not very meaningful, I think, to say to people, oh, well, are your glands 5 centimetres? But I'll often say, well, is it bigger than a cherry tomato or as big as an apricot? Or, you know, so I think people can relate to that well. And we also say to people between appointments, if you're worried your glands are getting bigger and you want to talk, ring Tracy and Sian, they'll have a phone chat. And then if we think that there is a cause for concern, we'll bring people into clinic sooner than planned. The lymphocyte, absolute lymphocyte count, we really don't worry about. But again, I think that's something that patients, primary care team, other people do worry about because they see the lymphocyte count going up. But by itself, I wouldn't treat somebody just because of their lymphocyte count. It's more the sort of whole picture of how quickly is it going up? Are there other features to be taken into consideration? Then 2 other things to mention that often don't get talked about are that people with CLL are more likely to have autoimmune problems. So by autoimmunity, I mean the body producing an antibody against its own tissues. So sometimes people are anemic not because their bone marrow is full of CLL, but because they're producing an antibody against their own red cells. And if you did a bone marrow test, you'd see plenty of lovely red cell producers in there, but they're getting broken down in the blood. So that by itself isn't always a reason to treat the CLL. And if people have that, we usually try steroids first to see if that can switch that off. But often people with immune problems do end up needing CLL therapy. Constitutional symptoms, by that I mean sweating, weight loss, fevers. They tend not to be very frequent, but we'd want to know if somebody had those symptoms. So what can you do to stay as well as possible on watch and wait? So a lot of this is general health and well-being, so eating well, watching your weight, not smoking, not drinking too much, being vaccinated as fully as possible, being vigilant for infection, but there's a balance to be struck. Again, the COVID pandemic really brought that into sharp relief. Looking after one's mental health. And when I sent my slides to John, he said, but you haven't put on physical exercise, which has provoked me to say, actually, I'm very interested in the interaction between physical and mental health. And the other speakers coming today, I think, will very much speak to that. You know, I run because I love running, but I also run for my own mental health and well-being. And I really believe that if you're physically fit and mentally in a good place, you're just in a better position to cope with the whole CLL roller coaster. Peer support, really important, CLL SA and the other patient support groups, really important. So if there are people here that it's their first sort of connection with the CLL patient community, I can't recommend it highly enough. And support from your clinical team. So wherever you're looked after for your CLL, you should have a consultant team, a named key worker who would normally be a clinical nurse specialist. In some centres, there's designated clinical psychology support. So the resources are all there for you. That was the prognostic markers that I've covered. And then finally, when you're nearing treatment, it's important to say that that need for treatment becomes apparent gradually. We'll start discussing it weeks or months before treatment's going to be necessary. There will be time to consider your treatment options, and we'll discuss that with you, provide written information, direct you to online resources. If I think somebody's heading towards treatment, it's a kind of reminder to me to say to them, are your vaccinations all up to date? Because we know that response to vaccines is better if you're not already on treatment. We screen for bloodborne viruses, if not done before, because when we immune suppress people with treatment, that can be a problem if people have sort of dormant viruses. You'll always be examined before starting treatment. I don't always do a CT, but often we'll do a CT, so a whole body scan, particularly if people have symptoms, for example, abdominal symptoms, but not a lot of glands that we can feel easily in the clinic to follow. Sometimes we'll do a bone marrow biopsy, not always. And sometimes we'll do a lymph node biopsy. We'll particularly do that if we're concerned that the CLL is not behaving in a standard CLL way.